And hello, I'm Dr. David Schmitz, and I'm happy to welcome you to Project Echo and continued in our learning series and sharing together our experiences across rural North Dakota. I'll be your facilitator today, and you can see by the red, white, and black signs where the hub sites are, and we really appreciate in particular our spoke sites out in rural areas of North Dakota, because remember, this is all about distributed expertise and how we can learn more together. I want to just make sure with a couple of housekeeping items that you'll recall that the disclosures have been sent out by email with the links to the pre-test, the post-test, and also the evaluation. And so you can get that CME credit. Please do complete that pre-test and make sure to sign into your roster at your site prior to beginning here this day. Additionally, I just want to make sure that everyone recalls that you should stay muted with regard to your audio unless you're speaking. And if you would like to ask a question, there's a couple of different ways to do that. You can actually use the chat feature in the Zoom platform. We'll be moderating and watching for any questions or comments, or you can simply unmute and ask the question. Soon I'll be turning it over to our speaker today for the didactic, and then also let you know that we won't have a case presentation today, but we'll have some discussion following the didactic presentation by Mark Schaefer. And so without further delay, unless there are any questions, doesn't look like it. Somebody give me a thumbs up that you guys have been able to hear me for the last 2 minutes. Very good. We've got an interactive audience already. So I'd like to introduce our presenter. Mark Schaefer is experienced in this realm. I really appreciate him joining us today for this didactic in particular. Mark is currently the Vice President of the Northern Territory for Community Medical Services, and this actually does include North Dakota as well as Alaska, Montana, Ohio, Indiana, Michigan, and Wisconsin. So a lot of breadth of experience there, and a lot of rural too. Prior to that position, Mark worked for 15 years with the Dakota Boys and Girls Ranch with residents as a staff therapist and clinical director. And after this, he worked with Lutheran Social Services following the 2011 flood with the crisis counseling program that served residents in Minot, Grand Forks, Bismarck, Devils Lake, and Fargo. So Mark knows North Dakota. He also spent years at Head Start Collaboration Office Administrator within the Child and Family Services, working with programs across the state. So with that introduction, Mark, I'd like to turn it over to you for our didactic. And again, really appreciate the experience that you can bring to our discussion here today.
Well, thank you very much, Dr. Schmitz. I am not sharing my video right now. I'm in a hotel in Wisconsin, so I apologize. I also have a little bit of a head cold, so I don't know if that improves or makes it worse, but I'm going to share my screen here with the standards of care. And what I'm hoping, can everyone hear me okay? Looks okay. What I'm hoping in the discussion is certainly, I cannot claim to be an expert on these areas, but I do hope to raise the kinds of questions and the kind of issues that we definitely see quite often. One benefit of being in several of these states is just seeing different ways that standards are applied in the different states, some where they're more loosely applied, which we see some issues with, and some where they're more stringent guides are put in place that really kind of hamper some of the work that people are trying to do. And so there's definitely a wide variety of ways that the regulations are interpreted and put into place in different states. So I'll be focusing on North Dakota for our purposes, but as we discuss it, I hope to raise some of those issues. Very briefly, I think this is in the questions, just going over the standards of care, medication-assisted treatment, identifying strategies that meet federal guidelines and contribute to success, and I'm going to move that, applying the standards to client cases. So I don't have specific cases in there, but what I did do is lay out some very, very common scenarios that we run into, and I'm sure people will be able to identify with those and discuss just different ways that those can be addressed. Looking at that, I'll start out just talking about the components of MAT, the balance of diversion control, which I'll talk about more, but diversion meaning the medication being diverted by the client out into the community versus client care, and then applying those standards to common scenarios and some different models of care that we run into and that we provide. So when we look at medication-assisted treatment, obviously there's a lot of different viewpoints on that. One of the things that we often highlight is really highlighting that medication-assisted, that it is not the medication alone. We do look at, there is the pharmacological therapy that's provided, and there's been more than enough discussion on these areas, but just looking at the different federally approved medications that are available, being able to provide all forms of the medication is definitely something that is recommended. It is, different people respond differently, but just having some form available is also preferable to none. Looking at provider and community educational intervention. So one of the things we see, honestly, as I've gone through 7 different states, North Dakota is really quite progressive in how the community responds to medication-assisted treatment. We do run into a lot of communities where, not in my backyard, where the concepts of what medication-assisted treatment is really lacking. And so we do see, as part of providers of medication-assisted treatment, that we need champions all across the field to provide that education to individuals, and also to help really reduce the stigma that our clients are facing. So it's not just, we look at individuals with a substance use disorder running into stigma, and then within that subset, you have people within medication-assisted treatment who are further stigmatized, because people don't always believe in different pathways to that treatment. And so providing that education is really crucial, both for the services to work, but also for our clients to get the care that they need. Integrating with other medical and treatment societies. So I look at opioid treatment programs specifically, are providing a sliver of the services. It is not in all cases as comprehensive as you would like. Good examples, though, Coal Country, Heartview, where there's a wide range where those services are provided, are really ideal models for those. But for areas where you have, outpatient based, where you have, the medication and the counseling provided, but it's not sufficient alone. So we really look at that coordination of care, and I'll talk about that later with the federal regulations also. But that coordination of care is crucial, having good relationships with the community, with other providers. We look at, for our clients, we don't want to just refer them to another provider. We want to be able to say, here's Joe, we know that he's going to get these services to you, because we know that we're not providing everything that's needed. And so it's really crucial for that. And then, of course, the psychosocial services, the counseling is just crucial. We see so many people who, and I'll talk about this also, but just the temptation is, once the medication starts to take effect and you start to feel a little bit better, I see this stages of change kind of very quickly go through different stages, where the contemplation and the action all of a sudden become pre-contemplative when looking at coming in for counseling. The medication will start to make someone feel much better, but then there can be just a loss in some of the motivation to complete some of the psychosocial things, because you're addressing a lot of difficult issues, and so that's a part that we really see needing to be addressed, and addressing it at different stages, that we're not just looking at it in one fell swoop. And this, I'm going to go fairly, I don't want to over address some of the things that have already been discussed, but please do raise hand. I cannot see if someone raises it, so I'll rely on someone to just stop me. But looking at, so first, just talking about methadone and some of the federal regulations along with those. And for us at Community Medical Services, we also apply these to the Suboxone. So in some states, we are able to dispense Suboxone. So it is not written as a prescription. It's actually dispensed in the clinic, so that you have some time, but the rules are definitely much different. But we look at some of the issues that come up with the pharmacological therapy. Take-home medications. Take-homes are where you look at that balance between diversion and stability for the client. When you're looking at deciding if take-homes can be applied for somebody, there's these criteria that you can see. I won't read through all of those, but in general, you can see that it's looking at, it's really quite high standards. You look at medication being safely stored, the outweighing the risk of diversion, time and treatment, stability of the environment, criminal activity, and then the abuse of drugs, including alcohol, of course. And so one of the things that we often have to address right away is that it is extremely intrusive for someone engaging in an opioid treatment program, coming in every single day. At the very least, they're coming in 6 days a week to receive that medication. There cannot be any missed days. There cannot be missed appointments. For any of those things, it would be considered not meeting the criteria, in which case take-homes would not be allowed. And the time in treatment is up to 90 days to go beyond one take-home dose. And so for Heartview, they're open 7 days a week. For community medical services, we're open 6 days a week. So after 90 days, a person, if they have perfect attendance, do not have positive drug screens, they will be able to get one more take-home. So they could come in Friday, get Saturday, Sunday, or in the case of with Heartview, they'd come in Saturday and get their Sunday dose. Then it's going to be upwards of 2 months of continuing that behavior before they can move up to the next level of take-home. So one more dose, and up to about a year before they would have about a weekly 6 doses that they would be able to go through. So as part of that is just to make sure that, I mean, it is a good rule. I don't have a problem with it. Travel in rural areas definitely makes for difficult when people are needing to travel every day. But part of that is also to work on the diversion control. And so for every program, you have to have a plan on how you are controlling diversion. And so that can include, as it says there, take-homes are tied to the stability. In addition, reductions are tied to that. And so if someone has weekend privileges where they come in on Fridays and leave on, or do not need to come in Saturday, Sunday, but they miss a day in the clinic, don't show up for an appointment, they may have that privilege level reduced. And then the callbacks or diversion calls. And so when someone reaches a weekly level, or if they go up to bi-monthly where they're coming in twice a month, they will get a call back at a random time and need to come in within 24 hours, bring in the bottles, bring in the medication. They'll have to take their medication that day at the clinic. And then all of those bottles are, of course, checked for consistency, that the right bottles are there, that the dates are there. And if that is failed, then that person would be losing those privileges. That is part tied to the federal regulations and with the DEA, where you need to be able to show that you're controlling the incidence of medication being diverted into the community. One thing that gets lost in that sometimes, though, is that the dosing is not tied to the behavior. So an individual's dose, whether it's 60 milligrams, 100 milligrams, 150 milligrams, would not be tied to that behavior. So if a client is not making an appointment, if they're not working through in their counseling sessions, you would not reduce their dose based on that. They may not be able to take the dose out of the clinic, but the dosing is not tied to that. One of the things that we do often see, despite the fact that that is not allowed, it's expressly forbidden, we do see where that does happen when we've seen it at other clinics. And it's really dangerous because you need to look at, obviously, the temptation is to reduce a dose, which is just putting the person at a higher risk for illicit use and an overdose. The other is dual enrollment. So in North Dakota, there's 3 opioid treatment programs. So anytime a person comes in, Heartview Community Medical Services will fax that information after the release is signed to the other facilities to make sure that they're not enrolled in both facilities. In addition to that, the PDMP is always checked upon intake once a month in North Dakota by licensed addiction counselors, but also when clients are seen by medical providers to watch for if there's other Suboxone scripts, if there's current medications that could cause issues, or if there's opiates that are being prescribed.
And Mark, just a quick question from one of our participants. Are the daily rules that you're discussing regarding the medication also applicable to buprenorphine as well as to methadone?
Right. So in states where it's dispensed, it's very much up to the clinics. And so in North Dakota, there is not anywhere that it's dispensed. So it's prescribed, and so it is not. Those rules do not apply, nor does the DEA or the federal regulations apply those even when we dispense them. So for our clinics, say in Montana, where we dispense it, they're able to move beyond daily take-homes much quicker with the naloxone, or I'm sorry, with the Suboxone, just because of the risk with the diversion is much smaller than with the methadone. Well, not the risk of diversion, but the damage than the methadone. But that is not required by the federal regulations. So these are very much tied to the methadone. For Suboxone, technically, the prescription is determined by the provider, whether it's 3 days, 7 days, 30 days. So when we look at just standards of care, things that are important, these are not requirements. So we look at these more as best practices. For us, increasing providers is hugely important. I've often said, I would love for more providers to be available. There's not enough of us to go around. There's no competition. There's just so many people who are needing treatment that I just couldn't see us ever having too many. And so I really do see, and it's one of the differences I think we've seen in North Dakota, as opposed to competition, that people are just willing to reach out to help, to work with others, to get more providers into this and to increase the knowledge that people have out there. Again, I talked about this, so I won't go into it too much, but the stigma and shame, we do have clients who would like to go through the Al-Anon or Narconon type groups, and some are much more open than others. There are some pretty open groups for that, but other groups do not consider medication-assisted treatment to be abstinence, do not consider that to be engaged in treatment. And so we do have, even within the treatment community, where clients are not being welcomed. And we have residential centers, and we have substance abuse treatment providers who are not on board with medication-assisted treatment. So it's not just the stigma and shame that we see in the community, but it's within even our own providers, our own systems, that we see that. And so really getting the word out, getting education, and getting people who embrace it, as they put there, it's not just tolerating it, it's not saying, well, I guess that's okay, but really embrace and support people who are going through this process. It is just a massively intrusive process, and I think oftentimes, because it's not residential, people do not see it as taking quite the commitment. Whereas I would take the opposite of that to say that I just see our clients are really, living in the community, living in the network of people that they have lived with, and trying to go through this process is just really quite heroic for them to do that. And then creating awareness of the options for individuals. So there's not one path, there's not one way. And so I think it's important, as we look at medication-assisted treatment, is not for everyone. For some people, they are aware that might just continue to provide difficult triggers, situations for them. And so not just sending them away or giving them a card, but working with them to get them into the appropriate treatment. So we often let people know that they may not be appropriate for our treatment, but to come in anyways, and we can spend some time with them to get them and find the right provider for them. And I think that's part of, with medication-assisted treatment, and with introducing that in some communities and increasing its awareness in some communities, is also that integrating with people and working with and coordinating with other providers to not see it as us versus them, or that one way is better than the other, and just prioritizing what's best for each person. So on that note, just one of the things that coordination of care is required. So when someone comes into treatment, they do sign a release of information so that we can ensure that their primary care provider is aware. So because of the rules around 42 CFR with the behavioral and the medical, the methadone will not show up on the PDMP. And so a medical provider would not know if a client was enrolled in an opioid treatment program, being prescribed or being ordered methadone. And so we do require that coordination of care so that we can notify providers. I would say this is an area definitely where we could see some improvements or work with improvements. I imagine that medical providers have a lot of paperwork passed through their desk, and so getting one more piece of paper that and trying to match that to a client could be very difficult. And so finding ways to create triggers so that it would come up to the top. I know Trinity Hospital was looking at some ways. They have a different flagging system for different things, but that's definitely one area where, of course, too, a client can not report who they're seeing, or they may not have a primary care provider. And so that's a constant issue. The North Dakota Health Information Network, opioid treatment programs are allowed to be a part of that. We cannot upload any information, but we can check that information so that if a client is not telling us that they have a primary care provider, we are able to check that. Of course, still need a release of information, but if a client will not sign a release of information, that could be grounds for being dismissed from the program because of the damage that could cause being prescribed other medications and just possible health issues that could come up without having that coordinated care. We do see one of the biggest things in the first 90 days, while it's counseling is provided, we do utilize case managers because the first 90 days at a minimum really are focused on that hierarchy of needs of getting home back, getting vehicles, family, children, employment. Many of our clients, of course, have a corrections background, and so very difficult to get back on their feet. And so a lot of the work that we see is happening is just within getting kind of those basic needs being met. So that's part of the reason why you look at the long term of treatment for medication-assisted treatment. One, just so that you can get to a dose that is keeping someone out of withdrawal and being able to function normally, and then being able to titrate down when they're ready, but also to give time to get some normalcy back into life and then work on those issues that we see so important in their daily life. And the graphic there is just one example of just some of that coordination of care that can take place in a large system where really needing to be a part of all of those different service providers in different areas. So with the psychosocial services, again, as I talked about, it is a phenomenon we often see is once the physical withdrawals have been addressed, the urgency for seeking treatment we often see a decrease in that. So the medication is helpful, but then we'd see that lack of motivation to engage in some of the treatment. And so that's something that people should be aware as they work with individuals, that is something that's not uncommon, and that you just match those interventions that you're doing, right? When you look at your motivational interviewing to address that stage, that can happen, and just to be prepared for that and be able to address it with individuals. There's minimum requirements in opioid treatment programs of meeting with the client monthly. What I would say to that is a minimum requirement, not a best practice. And so each individual goes through the behavioral health assessment, the treatment plan is developed, and that should determine the frequency of those interventions being provided, not the minimum that's required from the federal regulation. Having partnerships with behavioral health providers is very important. It's a specialized service for this. Agencies that have that continuum of care, I think, are in a prime position to really provide that. For those that are more satellite or don't have those available, creating those relationships is going to be very important. And one of the things I see with our outpatient providers is finding ways to connect with those. I think some of the hesitancy for some people who have gotten their waiver to provide the service is not having that connection with somebody who can assist with that case management, with the behavioral health services. And so I think that's a huge part that we need to find a better way to network with individuals. And again, it's not tied to the dose. So someone who's not engaging in their counseling services should not have their medication changed or lowered. That's just another issue to deal with in the counseling. So just, I won't linger on this one too long, but just the balance that we constantly see, and the biggest issue that comes up is that client-centered care and diversion control. Most of the issues, so I work with about 14 clinics right now, and most of the issues that create the most consternation is balancing the policies, those guidelines, along with client-centered care. When you look at some of the harm reduction principles, it can be easy to say, well, you know, they're going to drop out of treatment if we do that, and then they're going to go out, they're going to overdose, and they're going to die. That's the first thing that comes up. A counselor often will bring to me, or a medical provider, and they'll say, well, just let them go. Just, you know, it's not a big deal. Let's, and there should be a balance, but that's the most common issue that I see. And the one that's most difficult to deal with is balancing, you know, at what point, what have we done everything we can? You know, does the risk of that diversion outweigh the consequences of that? It's a pretty wide open, it's pretty gray. It's not defined well federally. And so your internal policies and procedures are designed to provide that. And so for community medical services, that's one of the areas that we're constantly looking at, how we define those consequences, how we define what those might be. And so I'll do this pretty quickly and we can come back to it, but just to get these out here. Some of the most common areas where we see, I don't know if when I move this screen around, can anybody see the other video, or is that not showing up for you?
No, we're not seeing anything.
Okay, good. So one of those is positive drug screens. So there's different areas that this can come up. We see, and differentiating those. So random screens are used as part of the diversion control. Some of the different things you can see is continued opioid use. Then there's decreased opioid use with consistent illicit use. Most often we see cocaine and methamphetamine. Those can be very different issues as you address those. For some individuals, they might see it as, well, they're continuing to use, so we can't keep them in treatment. For others, we'd say, well, the medication is working for the opioids, so let's continue to work on the other issues. And then you have this random positive drug screen that can pop up for somebody. Obviously, every one of those are opportunities to meet with the medical provider, the counselors, the treatment team. But they are definitely determining when to stop. I think one of the most difficult things we see with the methadone, because it's dispensed at the clinic, you can move to daily privileges where you see that person every single day. It provides a lot of safety for that we can control some of that. What we see the most difficult for is our providers who have that option, and then they have clients who are being prescribed Suboxone, and the client struggles. The client maybe isn't coming in for appointments. It's 3 days after their medical appointment, and now they're out of medication, and so they've come in 3 days later promising to do better, to work better, and you don't really have an option of saying, well, come in every day. You know, you could say, come in every day and take your medication here, but how do you control those? So that's where we see a lot of difficulties and hard choices of, you know, at what point do you stop writing that prescription, and what are the options available to you? And so again, the psychosocial, having a team that can work with those things, and having some options. It's one of the reasons why we do want to try to get dispensed Suboxone available, so that there's just one more level of care for that. And and providing those. Again, also when you have multiple levels of care available, those are things that can be offered. And if the client chooses not to do that, then you continue to work with what you can. Concurrent medications, so the dangerous, alcohol, benzodiazepines, I think that's been discussed quite a bit through Project ECHO, so I won't go over much of that. Marijuana, of course, is going to become more of an issue of how to address that. We have, one example is continued use puts the client at risk physically, so alcohol and benzodiazepines are ones where we feel pretty comfortable being more restrictive and saying that, this is a high risk for overdose, it's a high risk for heart failure. We're not going to continue to dose at that. But then there's also when continued use puts the client at risk for stability. And so clients who are using marijuana, will often make the argument, well, it's not causing any problems. It's not, but they're also going to their dealer's home, or they're putting themselves in risky situations. They're putting themselves at risk for violating their parole, those types of things. And so how you address those are ones that come up fairly often, unfortunately. And then program expectations. AWOLs are one that we see quite often, just not coming into the clinic. For us, when we have an AWOL, that's usually going to be a reduction in the take-home privileges, not as a punishment, although it very clearly feels like that. But when someone is not coming into the clinic and taking their medication, it means there's a good chance that they're going to go into withdrawal, and that means that there's a good chance that they're going to engage in other activities or illicit substances that are going to be unhealthy for them. And so we want to get them into the clinic, find out what's going on, why they're missing. There's a big difference between someone having their car break down and not being able to make it, and someone who is starting to slip back into some behaviors that means that they're using illicit substances again. And then there's the avoidance of the counselors or the medical providers. And so determining that level of, one of the things I should have started with this, but it takes a fair amount for us to discharge someone from our program. Medical director is involved. The treatment team staffs it several times. There's several steps before that would ever take place. But there is no black and white line that we have other than threats of safety. So someone threatening harm or engaging in that. Apart from that, there is no black and white line that we use for determining how many times you miss a counseling appointment, because it's not that black and white. There's different reasons, there's different things that happen. We know that people are trying to get back on their feet, and so staffing each one of those can be a real difficult issue. And so having program policies and procedures that at least provide some guidance are where we see probably the most issues that come up around these situations. And finally, just a quick, when we look at the models of care and some of those that are available, I've talked mostly about the opioid treatment programs that can dispense the 3 different types of medications. Currently in North Dakota, you have Heartview and Community Medical Services that can dispense all 3. There's also, when you look at of course, the outpatient-based opioid treatment, where we're seeing a pretty large increase in the number of providers who are waivered. One of the things we're doing with the state is working on identifying individuals who not only are waivered, but are actually prescribing as well, so that we can increase that. A model that we've looked at in Vermont, of course, is the hub and spoke, where you have an opioid treatment program, and then you have these satellite clinics that are able to provide care as people progress through treatment. One of the things we did find with that is the geography is a little more conducive to that in a smaller state. So for a hub to be in Minot and the spoke to be in Williston, 2 hours is much too far to say you're going to have to go back to a daily prescription and drive 2 hours every day. And so in Vermont, they were looking at places where someone might be in the city and go to a clinic that's 5 miles away. And then if they regressed in their treatment, they might come back to the hub, which was, again, only 5 miles away. So it worked much better. The other is emergency department initiation. And so when someone has come in for an overdose, they've been revived using naloxone, there is the ability in the emergency department to initiate methadone or buprenorphine, Suboxone, for up to 3 days. The person has to come in each of those days, but it does provide an opportunity to start someone inducted as you're getting them into a program. And so it's something that's being piloted. I mean, it's available in many states. It's piloted in some states where they're trying to find different ways, and peers are a big part of that. But it does provide, obviously, because after the overdose and after being revived, they're at a very high risk for overdose again. So those are just a few of those models of care available. That is the bulk of that. I did rush through those, the 3 areas that we kind of see the most issues with clients. And so if there are some of those that we want to discuss more, I will stop talking so that we can.
Well, Mark, thank you very much. Again, this is David at the Hub site, and we're open for some questions and discussion. I know I've got a couple of thoughts myself, but let's go ahead and see if someone would like to chime in here to start. And I think, Dr. McLean, did you have a question or comment about community?
Actually, Mark, thanks for presenting, Mark. You actually did already discuss that when you were talking about the reluctance of some communities, including addiction treatment communities, in kind of MAT versus others that do. So when you initially started out, I was just wondering if there was a particular community you were referring to, but you already answered that.
Thanks, Dr. McLean. Andy, while others think of their questions, I'll ask a quick question. It seems to me like technology is really advancing with regard to healthcare delivery. Everything from televideo communication, making platform-based synchronous or asynchronous check-ins possible. You know, you can now deliver primary care as a family physician through your smartphone app, in addition to consultation. But I'm talking about patient and clinician interactions. I was just looking up on I did a quick price check, which didn't take me very long. For about $150, I can purchase a medication dispensing unit that has a number of days of medication, and the door opens on time. It's connected to the internet, and if somebody tries to get the door, I think it's designed for a person with memory loss, Alzheimer's type early dementia. If you try to force the door open, or if the door opens accidentally, the patient might get double dosed. An alarm goes off and notifies somebody. So I'm just thinking of that drive between Williston and Minot, North Dakota, today, as we have a winter advisory, and it's not even December yet. What do you think about, will we need, what will it take, or how close are we to seeing the advent of technology and delivery really making this not only more available, but more efficacious?
They do have, that's interesting. They do, and Vermont was actually one of the ones piloting this as well. They are utilizing for Suboxone. There are some states that allow the diskettes for methadone. Most require liquid because of diversion. But they do utilize a system in Vermont where they have the medication is provided, and they actually use an application with the client. The client at a prescribed time will go on. They have a video that comes up. It comes out of the small dispenser. It's a very small dispenser. They take that medication. It's observed by a nurse. It's uploaded live, obviously all compliant with 42 CFR and HIPAA, so that they can provide those take-homes and a little more security for the client and for a nurse who actually observes it through telemed. So the provision of the medication, they're really starting to see some different ways. I know there have been some states that have looked at actually standing more similar to what you were talking about there. Of course, safety, there used to be talks of mobile methadone units. Those have kind of gone by the wayside. There's a lot of concerns, obviously, for security. The telemed is something that we utilize quite a bit, of course, in North Dakota with the scarcity of licensed addiction counselors. Everybody's looking where we can to get people connected, but also for medical providers to be able to connect with the clients has been utilized quite a bit. So I think it's a necessity. I would see medication units are another thing that opioid treatment programs are extremely expensive. Medication units are kind of like a satellite of that. So for an example, Heartview could have, they have their main clinic in Bismarck, but they have a medication unit, say in Dickinson, where a client comes once per month to the home clinic and then receives their medication in Dickinson, which is much more feasible economically to have. You're just going to have a nurse for a few hours and the medication, and you're not staffing a full clinic. You're providing most of those services out of the home clinic. And so there are some different options available and more becoming available.
Yeah, it seems like a good fodder for discussion as far as, planning a network across our state to support MAT in the face of opioid use disorder. I know we've got a good question from Cole County regarding emergency department initiation, and I'm so excited everybody's so interactive today. So I'm going to just ask them to ask the question themselves.
I think they're still muted.
Yep, we're unmuting them. It's totally worth it though. So great.
We're trying to set up an ER dispensing Suboxone for just what we reviewed here. But do our providers need to have an FCEA number? I don't believe we do.
Right.
Just something
So
for the providers to start it.
So I'll answer, and I'll look for Dr. McLean to make a face if it's different than what he would. For dispensing, so when the medication is ordered and dispensed in the ER, then the waiver is not required. So we have our medical providers, when we dispense in Montana, that does not count against their waiver. But once a prescription is written, that person goes on their waiver, and they must have the waiver for that. They should have, it's an 8-hour training, so I would definitely recommend that, of course, but, and again, I'll defer to Dr. McLean.
Well, yeah, and maybe Lisa might know this too, or Dave. Typically, whether it's methadone or Suboxone, a hospital can dispense medication up to 72 hours. The light just went off if I don't move. But you might actually check with Mark Hardy, who's the pharmacy director here in the state, on what the rules are after that. There's a lot of talk going on right now with the Ryan-Haidt Act and the ability for healthcare organizations to be able to set up their own clinic number, et cetera. But I think that the hospital is allowed to, because they have a separate pharmacy number, and the rules, at least with methadone, have been you could dispense up to 72 hours. Typically, you were doing that, though, for withdrawal management or pain, as opposed to MAT itself. Lisa or Dave, do you have other?
My only comment is I think methadone, at least in another state, as being dispensed by the hospital, was for pain.
This is Kurt Snyder. If I could just interject a second. Federal guidelines do allow for emergency rooms to do the medications without the waiver, so that is correct. I actually had a conversation with in Denver with a group, and I think it was a federally qualified healthcare center that had done it with incredible results in terms of decreasing the traffic of the overdosed individuals through the emergency room, which in our discussions in Bismarck with the emergency rooms, that's their biggest concern, is that if they start to do that in the emergency room, that they're going to get all these people that are going to continue to come back to them. But I really foresee this as a solution to this new revolving door that we're creating with people that are being revived from overdose that end up going to the emergency room that aren't connected to care, but just go back out, and we have this continuing group of people that are getting the Narcan, but not into the services. So I'm really excited to hear that Coal Country is looking at that. That is incredibly exciting. And I sure would love to see North Dakota take some steps to make that happen, because I think that the bridge, if we can get some capacity, that bridge is going to be incredibly helpful to moving people into some stability versus that continued overdose, which, you know, the more they overdose, the more they're at risk of eventually ending up dead.
Well, thank you for that discussion. I think in the same spirit of talking about the transparency of care and also the coordination of care, I guess I'm just wondering if anyone has any comments around 42 CFR Part 2, which does not have methadone reported in the PDMP without specific patient consent. You know, it certainly seems like if I was a family doctor in a rural ER, it would be very helpful clinically to know that someone is taking methadone, especially because of its very long half-life. Let's say I wanted to treat that person for alcohol withdrawal and they weren't able to tell me they were on methadone and I was going to use benzodiazepines. Or, I don't know, I can come up with multiple scenarios where checking the PDMP is something that is very useful for patient quality of care and frankly for their own outcomes. I understand there's privacy protections that are instrumental in 42 CFR that may be distinct from HIPAA, but any comments of people who may be knowledgeable of where that law stands? I understand it's a federal jurisdiction.
Dave, this is Lisa, I have a clarifying question. Does anyone know whether the use of methadone for pain, for the indication of pain, is reportable to the PDMP, or is it just globally not reported to the PDMP across the board?
This is Amy. Methadone for pain, if it's outside of an opioid treatment program, has to be reported to the PDMP.
Okay.
And Suboxone, when prescribed, is reported to the PDMP. So
Right.
I'm torn. I know that my CEO would probably kill me for this, but the opioid treatment programs are often pushing against that because of stigma, those types of things. So I get that, but I also would agree. We have Suboxone being reported, so people are aware if someone's being prescribed that. And I do see a lot of dangerous situations. I think it seems to be mainly that the concern of stigma if someone goes into their primary care or something like that, but the coordination of care is required already. So it is a concern we have, and trying to find ways to, like in an emergency, when someone gets in a car accident, I can't get a signed release, to let that doctor know that this person's on 150 milligrams of methadone. So it's a concern.
Yeah, so I think that's at least from a provider and care knowledge point, knowing that you're not going to see that in the PDMP, or you're less likely to, is a good point, take home point from today.
There is, just as a note, and Kurt, correct me if I'm, but if not that this is easily done, but knowing the few OTPs that we do have, a provider can call and they can verify because of there are situations, right, life-threatening emergencies that would allow that to be disclosed. And so, like, we have providers who are available. I'm not going to say it's easy right now. We're trying to make it easier, but where they can call, get a doctor who can check and say, yes, this person is, and this is their dose. They can verify the person, the dose, and the last time they dosed. Right. Again, not easy. We need to improve it, but.
Well, clinically, I think most people would err on the side of, the imminent risk. And so I think most people would say, yes, this person is taking this. You need to know that to avoid, death. If it's beyond that, if it's not as imminent, then you're on shakier ground. But I don't know of anyone who's been sued for responding in that manner and documenting as such.
Yeah, and we have had those calls.
Yeah, I would agree with that. I would say that in the last rewrite of 42 CFR, there was initially the push was that they were going to remove that, but they took it out at the last second. And that rewrite wasn't that long ago. Right. So I really don't foresee, this is an issue that I don't think we have the ability to change in North Dakota. We just have to get smarter about, like what Mark is saying, about being able to coordinate care and coordinate those efforts for safety. because, North Dakota Health Information Network is not going to be able to or the PDMP is not going to be able to over or supersede that as it stands right now.
Along those lines, I'll just jump in with my third question. Actually, that's just a question for you, Mark. I know you said having policies or procedures, is really helpful and really important. Is there an opportunity, do you think, in the future to share some of the policies and procedures that you have all had, realizing and recognizing they may need to be adapted to a local or rural environment?
Yeah, absolutely. That would be great. I think that's something we just went through, a massive rewrite of our policies and procedures. And it is, I'm not going to say it's an enjoyable process always, but extremely important because there is the federal guidelines do not, they do not clarify some of those. And so it's so important for the providers on the ground and at that last moment when there's, no one to reach out to, that you have those in place and how you interpret those and how you understand those. So definitely and that's part of the STR work that's being done too, is to have some of those resources available.
Excellent.
So to get a framework.
Mark, this is Lisa. I was going to ask you, I really appreciate what you're saying about sort of solid in the center and flexible around the edges, that you have to have sort of standards and core principles that you work off of, but there has to be some individually tailored interpretation of that. And you also talked about, the decisions that you make that impact people, you don't make them lightly, and you use your team. For example, keeping people in treatment or not, and discussing with a multidisciplinary team the things that you do that are hard like this. I wondered if you have any thoughts on the kind of increasing trend that we see, I think both in North Dakota and in other settings, for MAT to be provided as a sort of a single service without any of the sort of ancillary services and the coordination of care. Do you have any concerns about that? The reason I asked was because I was thinking about when you're up against these really difficult client decisions where you use your team, do you think it's problematic for those facilities that don't have a team and don't really work into the coordination of care arena?
Yeah, absolutely. So I would consider, like, community medical services, I think we're pretty small. Our teams are 5 or 6 people. And even within that setting, I think it's difficult. That's why I look at like models like Coal Country and Heartview, where you have a wider range, is just so much better for the client. We do see, with the medication alone, it's the hardest because we have our dispensed medication and we have our prescribed medication. We really get a stark difference. And even within a setting where we have a team, where we have case managers, counselors, medical providers working, we have a much more difficult time engaging those clients. And so without that team, I would see it as being very difficult to engage clients, also keeping them safe, because that coordination of care is what's many, many times kept our clients out of harm's way or out of situations or being dispensed medications or prescribed medications that are counterindicated with each other. So I have several concerns with that. That being said, that's why I think, like, we want to increase OBOTs. But I think personally, the right way I see that is when they have that surrounding those ancillary services, finding a way to connect to that, finding treatment providers that are willing to reach across there and work together. And sometimes it's not economically, it's not the best, but it is the right way, I think, to make sure that clients are being helped, and that the medical provider, that's a tough decision to make. That's our own providers, when they're prescribing, the team can give input, but we're like, you're prescribing it. You have to make that final decision. And they really struggle with that. It's a very difficult thing to do. So yeah, I would be concerned personally.
I also had, if nobody else has got an immediate question, I had just an observation I wanted to make that has to do with the payer world. And I thought of this when Mark was talking about the discrepancies between treatment providers and the attitudes around MAT and some of the recovery community as well. But I just wanted to tell you all that one of the things that we are starting to see in the payer world is, I think, as the understanding of the use of MAT and how it fits in the continuum of care for opioid use disorders, there is now a movement for a lot of payers to begin to require programs as part of best practice to have the availability of MAT, not to prescribe it. You know, they're not in the business of telling providers how to do their work, but being able to offer medication-assisted treatment as part of a continuum of care and a menu of options for their clients and patients. So a number of payers are starting to do things that will steer patients and clients toward providers who offer more of those best practice kinds of things. And so that's just another source of influence, I think, in the field that will probably, hopefully, help move people toward being able to better individualize and to offer a menu of options that includes all of the things that are available in the best practices. So that's an interesting thing.
Yeah, I think maybe just today or yesterday it came out too. Massachusetts just ruled requiring the Department of Corrections to have that those are available. North Dakota, of course, is actually really ahead of the game in many ways, with the prison working with Heartview and with the jails in the areas.
Very good. I know Lynette Dixon's just off to the side of your screen here, and she's got a question for the group.
Just quick, did I understand you to say through the STR we were going to make available policies so that participants can, you know, through your work with them, but, you know, are they posted online somewhere, or will they be? Or?
They'll be, that's a good question. I'm not sure how they're going to do. So like, obviously community medical services won't necessarily put but we're creating the framework of policies because, like, as you had said, you know, they're different, but it's definitely going to be available as a resource, and reaching out to all health agencies, substance use disorder agencies, health centers. But that's a good question to see how it might be available to someone who wouldn't be contacted through those methods.
Right.
And then, of course, more individualized. So if having those available is one, but then also if there's further discussion wanted to just go through some of those, that is also available. So being able to sit down with providers who are actually using those policies and procedures in their practice to talk about how it might be applied differently. Or
yeah, that might be interesting to apply a rural lens to that, and maybe even look at that for future discussion during an ECHO.
Right. And the one thing I was mentioning, we support the Critical Access Hospital Network, and they share their policies amongst peers, you know, but it's a password protected, not just out on the web. So the members of that Critical Access Hospital Network participate in a conditions of participation call for their surveys, for example. And so then we will post policy samples for them, but it's a password protected site. So it's not just a free-for-all, you know, it's for those members, and then they can go in and access. That way they're not recreating the wheel, but and then, you know, through your technical assistance, walk through it, not just give them the piece of paper.
Right.
How to implement it or how they might consider revising it. So that's a thought as you're working with DHS, or, you know, if there's anything through ECHO that we can support, so it's not just all, you know, open to everyone. You have a little more control over who's accessing the information. So just a thought.
That's a good idea, and I would think too, like at least as a sample, I could get some of the at least related to Suboxone and buprenorphine, because I think that'd be more relevant for more of the group here, so that they could get a sample to kind of see if that's helpful. That's a neat idea.
The other thing, if I could mention, in terms of rules and regulations that are going to be changing over the next year, about a month ago, the president had indicated to Congress, actually had put forth a rule that they need to address the issue of telepsychiatry, teleprescribing. It has to do with the Ryan-Hyde Act, because so many states are just unclear, and they're kind of acting as they interpret it. And I think it's certainly been a barrier to prescribing in many ways. So there's actually a mandate that they do something legislatively with that question within the next 10 months.
We'll wait to hear more from you, Andy. You can keep us posted. That's interesting.
Yep.
Well, that's exactly what Project ECHO is for, is to be able to ask some of our questions, see how they apply to us and our situations, particularly in rural areas, but really learn from our hub experts. So other questions, comments, and discussion?
I have a question for those, maybe for Kurt and Mark, about the emergency room, the initiation of treatment in the emergency room. Is there any work or any appetite in the larger organizations to start considering doing that work in the emergency setting, such as what Coal Country is starting to do?
I'll let Kurt respond first.
Yeah, thank you. We've had a lot of feelers out there and have tried to work. Matter of fact, our medical director, her husband is an ER doc. So, we have connections, but they've been very resistant to that at this point. And I think that, it really needs to be somewhat of a top down in that. The administration needs to be giving them permission and the go ahead to do so. It's interesting when you look back at Reducing Pharmaceuticals Task Force. That group has done a lot of good work around reducing the prescribing that's happening in the hospital systems. They've taken a lot of action to rein in a lot of the prescriptions that were going out that needed to be reined in. However, they have not been open to this discussion. It's something that I've been talking about with the hospital systems locally here for quite a while, and I've just got no appetite at this point to move forward. So, I just don't know the answer to that at this point, other than, maybe a champion that would start moving that forward. And maybe Coal Country's the answer in that, really. We're also, I guess, having some discussions with an ER doc that's retired in Bismarck, really well-known Dr. Langang, to do some work with us. And my hope is that, once he starts to do some work, that might be an inroad into that emergency room world.
Well, that's great. Gordy would be great.
That's a little distressing, not that part, but it's a little distressing because in Bismarck, at least, I think it's known that you have a reasonably large availability for MAT, so that, it would be difficult for the emergency rooms to say, well, there's no one to treat these people. In Fargo, in this area, I think it's a little bit more limited, particularly in the integrated systems where we've really not seen any penetration of MAT thus far. So I think that's the area that we should keep thinking about in terms of how to put pressure. I was actually thinking about something that you just said, Kurt, earlier today, as we were talking about the opioid epidemic. And, I think in some ways the supply side, clamping down on prescriptions and reducing the supply and thinking more clearly about when and how to use opioids. That's a little easier for the traditional medical system, and I think they feel a strong sense of ownership about that, as well as finding alternative pain treatment strategies. And I don't think we have it all done yet, and I don't think that there are all the answers, but I'm pretty confident that they're going to get there. I have less confidence about the access to treatment side, which has historically been underserved anyway. And so I worry sometimes that there's so much focus on the supply side, and that, you know, when sort of the new wears off, or the horror of all of this wears off, we'll still be left with not enough access to treatment, not enough expectations around standards of care and how to give people really good treatment. Because I think it's easier for the medical system to manage and get their arms around the supply side. It's harder to get their arms around the treatment side, because mental health and substance abuse has historically been so separate from the medical mainstream, and maybe there's not such a sense of ownership, you know, like they really feel like they have to solve the problem. I'm not sure that they do always.
If I could follow up on that too, that's a great point. But one of my biggest concerns, and we're already seeing it, is the increase in heroin. And you talk to Bismarck Police Department, and they'll tell you that, you know, they had 7 arrests 3 years ago, and now they have 200. I mean, it's incredible. And not only the heroin, but also the fentanyl and the carfentanil that comes with the heroin. It's much more dangerous and unpredictable than the prescription medication that people are using. And so my big fear that comes with that, of course, then, is you reduce that supply side on the healthcare, in the healthcare community. But if we don't get the capacity built, you know, we have a wholly more dangerous scenario going on with these people that are forced to go to the street and buy this, you know, the heroin. But then also the stigma. You know, now it's easier to say those junkies and the heroin issue versus, you know, the prescription drugs. So I'm really fearful about that as that heroin increases, there's a pushback with the pendulum on the willingness to see this as a disease and to address it through a healthcare lens versus criminal justice lens again.
I think that's very well said. It's really a bimodal epidemic, because the face of the heroin side of it has a bunch of different dynamics from the prescription opioid side. And the stigma that you speak to, I think, is very real. And it sort of flows closely with what Mark talked about earlier today.
Well, a rich discussion for sure, and I think we've got not only the mission well outlined and some of the objectives, but the motivation too in today's discussion. I think we've got a few real practical ideas, and also took a couple of tidbits that we can put into practice today. So if there's not other comments, I want to thank Mark with regard to the presentation today, and actually all of our participants for a really interactive discussion.
Thank you.
Any other comments or questions? Very good. Well, Julie, I think was there a question? Julie's put the next ECHO date up there for you guys, but what is that, Julie?
It is December 12th. It is, oh boy.
Still winter in North Dakota
Yes.
on December 12th. So we'll talk to you then, and thanks. Be well, everyone. Be safe.